Course of the disease. The course of the disease is entirely irregular. The character of the symptoms bears no precise relation to the size or position of the stone, and the progress of the disease varies from the cases that have only a single fatal attack of calculus and urea, or that die of some intercurrent disease without ever having manifested any symptom referable to the calculi with which their kidneys are filled, to those that drag on for years with chronic renal suppuration and repeated passage of stone. Several types of the disease may be mentioned, due allowance being made for the fact that a given case is often a compound of several types. The surgeon encounters 1. Cases without symptoms, 2. Cases of renal colic, 3. Cases of calculus and urea, 4. Cases of renal distension, and 5 cases of renal suppuration. Cases without symptoms. The onset of symptoms of renal calculus is not the beginning of stone. When the minute calculus first forms in the renal pelvis, its place is determined by the shape and drainage of that cavity. If the pelvis is well drained, the urinary stream will sweep the little calculus into the ureter before it has attained any great size. It announces its passage to the bladder by a series of renal colics, even though it be extremely minute, no larger than a grain of wheat. But if the pelvis is not well drained, a stone naturally sinks into some calyx where it slowly and silently grows. At most, it causes a pyuria or a microscopic hematuria. But since this excites no subjective symptoms, it is usually entirely overlooked. Such stone, if actually silent, may be discovered only at autopsy or by the investigation that follows the disclosure of albumin and pus in the urine as the result of an examination for life insurance. Such stones frequently grow quite silently until the kidney is almost totally destroyed and the X-ray shows an enormous stone, plate 6. Although it is possible for stone, even bilateral renal stone, to remain thus silent for 20 or 30 years or longer. At the onset, or at least during the first 5 or 10 years of the disease, small pieces of stone are likely to descend into the bladder, giving a history either of renal colic or of vesical calculus. Later in the disease, the stone may cause slight, painless, protracted hematuria. It is very likely to cause some disturbance of urination and perhaps excite a great deal of bladder irritability. And when large, it always causes pyuria, albuminuria, and diminution of the kidney function. If all of these symptoms are either overlooked or misinterpreted, the patient may be left to die of renal insufficiency alone or excited by some intercurrent disease or accident. Figure 78. Also, plate 6. Renal colic. The preceding description of the general character of the attack of renal colic leaves only a few remarks to be made upon this subject. The course usually lasts only 3 or 4 months if the stone is to pass. But I have several times known a stone to pass from the ureter after 2 years of colics. Yet even when the stone has passed, the stone-forming habit is likely to continue, so that either from the discharge of calculi collected in the kidney pelvis above or from the actual formation of new stones, the patient who has once had renal colics is rather likely to have further attacks in later years. In one sense, however, renal colic with the passage of stone and no evidence of any deterioration of kidney function or accumulation of stone left behind in the kidney pelvis is a good omen, for it means that the kidney pelvis drains well, and that if subsequent stones do form, they are likely to be passed, as was the first one. Reflex symptoms. Other cases again give only reflex symptoms. One of my earliest professional recollections is of an old man who for years suffered only from painful and frequent urination. His bladder was washed, searched, sounded, and even cut, all to no avail. New York's best surgeons of those days could do nothing for him. Finally, his protracted agony was terminated by a fatal attack of suppression of urine, as it was called. Autopsy revealed a normal bladder and one kidney atrophied and tightly contracted about a calculus, the other somewhat dilated and with a stone plugging the ureteral orifice. Yet he had never complained of a symptom referable to either kidney. Calculus and urea. Calculus and urea is a stoppage of the urinary flow caused by the plugging of one or both ureters with calculi. It is part suppression, part retention. The terminal anuria in the case mentioned above was a pure retention. One kidney had been out of commission for years. The flow of urine from the other was stopped by the obstructing stone. In other cases, the blockage of one ureter throws such a burden of excretion upon the opposite kidney that it becomes acutely congested, and suppression ensues. Thus, anuria may ensue, 1, when both ureters are completely obstructed, or 2, when one ureter is obstructed and the opposite kidney absent, hypertrophied, or sufficiently diseased to be incapable of enduring the congestion forced upon it. The acute obstruction is clinically unilateral, but unless both kidneys are diseased, anuria does not occur. Pathology. The pathology of calculus anuria is striking and characteristic. The obstructed kidney, which may be hydronephrotic or suppurating, is intensely congested. It is enlarged to twice or thrice its normal size and is dark in color. On section, its tissues are found friable and edematous. Such a large, soft purple organ once seen is never forgotten. Figure 79. Figure 79, calculus anuria, the congested kidney. The stone was impacted lower down the ureter. Compare figure 80. The opposite kidney in all but 3 of the 58 cases collected by Morris was absent or completely disorganized. Symptoms. The symptoms of calculus anuria may be divided into 3 stages. 1, the premonitory stage. 2, the tolerant stage. 3, the uremic stage. 1. In the premonitory stage, there is more or less pain, perhaps an actual colic, referred to the kidney. It persists from a few hours to a few days. Figure 80, calculus hydronephrosis. A small stone was found lodged at A. This kidney is the fellow of the one shown in figure 79. They were obtained from a patient who died of calculus anuria. 2. The tolerant stage is characterized by but one symptom, viz. Anuria. The patient does not pass water. This anuria is rarely absolute. A few grams of urine tinged with blood are passed every day, or perhaps the anuria runs a remittent course. At one time or another, 2 or 3 liters of urine may gush forth, a misleading promise of relief, for the flow is but temporary. This state of affairs lasts from 3 days to a week. Not a drop of urine may be passed during several days, and yet the patient may, apparently, remain in the best of health. No more striking contrast could well be imagined than that presented by calculus anuria. On the one hand, the grave renal lesion, the absolute retention, the swift fulminating character of the uremic period soon to follow, and on the other hand, this entire absence of symptoms, local or general. The patient goes about well content. He eats, sleeps, and works pretty much as usual. Whatever pain he has had in the loin is past, and his present discomforts are insignificant. Yet all the while there is brewing within him a crisis, swift and terrible. Figure 81, calculus pyonephrosis. This kidney contained the stone shown in figure 77. Spontaneous recovery may occur. The obstruction is relieved. The urine gushes out 3 or 4 liters a day, and all is well. This may occur in 20.8% Morris to 28.5% Legueux of cases. In Legueux's cases, the spontaneous cure took place on the 3rd day once, between the 5th and the 10th day twice, later still in 5 instances. Yet it is obvious that one should not await spontaneous cure. When spontaneous recovery does not occur, the patient passes into the 3rd stage of disease at the end of a week or 10 days. 3. The uremic stage is usually ushered in by hiccup or vomiting. This is the first warning. It may continue for a day or two without additional symptoms. The pulse is tense, the temperature usually subnormal. Constipation becomes absolute, and the intestines are distended with gas. The vomiting grows more severe, the intellect becomes dulled and stuporous. The patient's mind may wander a little, and he may even have maniacal attacks. Thus, he sinks away and dies, usually within 2 or 3 days of the first hiccup or vomiting. Such is the clinical picture of what Morris has aptly termed the gravest and most fatal of the many serious complications of urinary lithiasis. Of course, there are atypical cases. The obstruction may be intermittent or partial, but such cases require no special notice. Figure 82, pyelogram showing dilated kidney and ureter pyelonephritis after removal of stone. Calculus hydronephrosis. Calculus hydronephrosis is due to the impaction of a stone in the ureter, figure 80, or rarely to a stricture secondary to calculus ulceration. The development of the hydronephrosis is habitually marked by a series of renal colics, and hydronephrosis may be one of the features of calculus and urea. The symptoms and signs of hydronephrosis are detailed elsewhere. Renal suppuration. Stone in the kidney is one of the most common causes of pyelonephritis. It also causes pyonephrosis, figure 81, while secondary phosphatic calculus or phosphatic deposit upon a pre-existing calculus results from the inflammation. The variations imprinted upon the classical picture of pyelonephritis and pyonephrosis by the presence of stone are few. There are the same urinary septicemia, the same local symptoms. There may be colic. Hemorrhages occur from time to time. The inflammation is rarely acute or virulent, but progresses slowly, terminating finally in pyonephrosis or perinephritic abscess.